It is my great pleasure to actually introduce to you a very eminent physician and clinician. This gentleman is a specialist in endocrinology. He's a keen and active lecturer. I know he came back from abroad only at the weekend, where he's been making presentations. He's the author of several published books on endocrinology. And for those of you who watch the television, one or two of you might, he's the person who made the programme The Fantastical World of Hormones on BBC 4 recently. So I'd like you to give a warm welcome to Professor John Wass.
And thank you for inviting me up here, and it's a real pleasure to be here. Now, just to begin with, please feel free to ask me questions as I'm going through. My object is that you understand virtually every word I say, so that's the first thing. And then the second thing is, can I just ask you, because I've got a preparation on various of the pituitary tumours, and can you just put your hands up if you've had a prolactinoma? Nobody, so I won't dwell very much on that. Has anybody, I know that there are some people who've had acromegaly, is that right? Yes. Are there some people who've had a non-functioning pituitary tumour? Right, I won't dwell very much on that then. And then there are some people who've had Cushing's, yes? Yes. Okay, and is there anybody who's had anything else wrong with their pituitary that I haven't covered? Right. Okay. So let's just, that gives me a little bit of ammo. The left one? Oh, that one. Okay, fine. Thank you. Right. So now this is two CT scans. Can you see them at the back there? But at the back, this is the pituitary gland, and in the middle there's a tiny dark hole, and that's called a microadenoma. And those tumours are very small, they're less than 1 centimetre in diameter. And if you do a scan of 100 people and look at their pituitary glands, 10 will have a pituitary microadenoma. So pituitary microadenomas are very, very common. What's important to know is that they virtually never change in size and grow into bigger tumours, and also that they may, but mostly don't, make hormones. Now, there's nobody here with a prolactinoma, so that they can make prolactin, which is the milk hormone. So I get patients coming to me who are male who say, I'm terribly sorry, I've got milk coming out of my breast, and that is caused by the prolactin levels on their blood being very high. And in women it comes as well, that prolactin levels are high, and in women with a prolactinoma, they usually stop their periods. And what I'm going to say to the commissioners is that actually another thing which is really important is that if it's easy in a woman because your periods will or will not stop if you're at that stage of your life. But in men, the problem is with pituitary tumours is that they become less potent. And that's not the sort of thing you discuss at a cocktail party. And so basically, your average bloke doesn't go around rather proud of this problem. And so this is why patients, and particularly men, present with their pituitary tumours 10 years later than women do, because women have an absence of periods, men lose their potency, and they don't say anything about it. And everybody keeps quiet. So that's why some men present rather late. Now, so that's the microadenomas, and those are tumours which are common but don't worry us so much. But they may make excessive amounts of hormone, and they may actually make ACTH, these tiny little microadenomas, and cause Cushing's. Now, on this side, you can't see it very well, but there's an enormous pituitary tumour here. And these tumours usually don't function. They don't make hormones. Now, there's nobody here today with a non-functioning tumour, but these are really quite common. And in fact, the prolactinomas and the non-functioning tumours are really the commonest of the pituitary tumours. Acromegaly is less common. We'll see that in a minute. And so is Cushing's less common. But because I'm so ancient, I'm getting a lot of medico-legal cases now of patients whose pituitary tumours have been missed. And often they're missed for 5 or more years. And the problem with these tumours is that they grow, and actually, just as you probably all know, above the pituitary is the optic chiasm, which is the eye nerves which come from behind your eye and go into the brain. And what happens is that the tumour grows and presses on these. And then, has anybody ever had visual field defects? No. Okay, well, what can happen is that the pituitary presses on the eye nerves, and I've got a patient whose notes I was looking at yesterday, and a number of the patient who I was up in the wash somewhere, and he'd had blurred vision for several years. And what had happened was that nobody had diagnosed it. And there was another patient who's actually had blurred vision. She went to her GP, and he didn't do anything about it. She also didn't have any periods, and he didn't do anything about that either. And 3 years later, a motorcyclist went into her side. And the reason for that was that she couldn't see him coming, because by that time, the pituitary tumour was pressing on her eye nerve, and she couldn't actually see out of the left-hand side of her eye. And that motorcyclist was in hospital for 10 days in the intensive care unit. So all of these things are entirely avoidable. So, Christine, I'm going to be telling the commissioners that they've got to pull their socks up and get us some proper services going. So,
what would be the size of that tumour? You don't mind me asking, what would be the size of that tumour?
Oh, they're 3 or 4 centimetres. Now, your pituitary is about 1 centimetre. It's about that big. And these tumours grow... Pardon?
9, sorry. Yes, 1 centimetre, that's right.
Yes, 9 millimetres.
9 millimetres, yes, that's right.
So a microadenoma is up to 1 centimetre, and the macroadenomas can be several centimetres. And they all grow. You can measure how quickly they grow, but they may grow at 3 or 4 millimetres a year. But what's interesting is that the macroadenomas, the bigger tumours... Yes, just a moment, I'll finish this sentence and then come back to you. That's lovely, you're interrupting, that's brilliant. But the macroadenomas, there are 1 patient per 1,000 with a tumour of the pituitary that needs treating. And so, for the GPs to say to us that they don't see it, well, in most practices there are 3, 4 or 5,000 patients. And that means that there really should be, and we've done this work ourselves, there really should be a few patients with a pituitary tumour in their practice. And so I think it's really important that we make sure that everybody is aware of these problems. Please, madam.
Is this something that the opticians will pick up as well?
Well, that's a very interesting thing. Yep. Very good point. There's a very famous optician shop that is in the dock over one of the cases I'm involved with, because they found a visual field defect and they didn't tell the GP. The GP referred them to the ophthalmologist, and the GP wasn't told, so she didn't tell the ophthalmologist. And so they all missed the fact that this person had a field defect. But you're right, the opticians should test your eyes, and if they're doing their job properly, they should also test your visual fields. Yeah, that's those little bit. And in the pituitary gland, what happens is that you can't see out of the outside of your eyes. It's this bit that goes. All right. So there we go. Now, this is so. I'm just now telling you a little bit about the types of pituitary tumours, and you all know these, actually. This is a slide I put up for our medical students, but you're much more advanced than that. And basically, there are prolactin-secreting tumours, which are the commonest, and then the next ones are the non-functioning tumours, and none of you've got those, but these much less common are growth hormone and adrenocorticotrophic. This is ACTH, and this one stimulates the adrenals and causes Cushing's, and that one causes acromegaly. And then there are various very rare tumours. So now, and what is the prevalence of these? And so what we did was to do a study in Banbury. And what we did was to get, I think, 100,000 patients. And what we showed in this study was that there were one significant pituitary tumour per 1,000. And this is the distribution of those tumours, that they were mostly prolactinomas. Non-functioning tumours were next, as I've said. Acromegaly and Cushing's is really incredibly rare. And when you get This is the problem, actually, that people don't recognize these things because they are very rare. And the other thing that's a problem is that when you have changes in your appearance, that they're not recognized. Now, I have diagnosed, a few weeks ago, there was this small child, actually, on the station in Banbury, and I was just dashing down to London, and he had a round face. He was very red. And I said to him, I think there's something wrong with you. And I gave him my card, and I said, and I wrote on the back my name. And I said, please will you go to your GP, because I'm sure he had Cushing's disease. And you see these people. And then there was somebody, I'm mad about opera. And there was somebody, I was at the Royal Opera House in London, and there was somebody talking in the row behind, outrageous behaviour, in the middle of the first act of an opera called Der Rosenkavalier. And I turned around to glare at him, and I realised he had acromegaly. Anyway, so I just stared at him, and then he shut up then. And then at the beginning of the interval, because you've got to be very tactful in these circumstances, I said, excuse me, have you heard of acromegaly? Because you didn't want him to be told he had acromegaly when he knew already. So he said, no, what's that? Anyway, so I then said, well, I think you've got this condition of overactivity of your pituitary gland. And he said, oh, well, anyway, so we got into I let his girlfriend go ahead. And then we got into a conversation, and I diagnosed his acromegaly in the Royal Opera House in London, and he's now cured. And I've done that once or 3 times now. I was dashing down, because I have lots of godchildren for various reasons, and I was dashing down, and I had all my shopping, and I dashed into a taxi outside Harrods, and blow me down if the taxi driver didn't have acromegaly. And so I told him. And then there was a 3rd time when I was flying, because it's a very busy life as an academic, and you fly all over the place and you give your lectures. And I was coming back from Santiago de Compostela in Spain, where they go for pilgrimages and things. And they have this wonderful thing called the botu fumera, which is a thing of incense, because all the pilgrims would come from having crossed over from France, and they were all extremely smelly, because they hadn't bathed for ages. And so they have this wonderful sort of suspension thing in the middle of the St. James's Cathedral of incense, because of all these smelly pilgrims arriving. Anyway, so I was coming back from Santiago de Compostela, and I was reading somebody's thesis, and suddenly this coffee arrived. And this great big hand, and I looked up, and the steward had acromegaly as well. So basically, I think it's a spot diagnosis. You know, if you're living with somebody and their face very gradually changes, then you don't see it, and you need to go back to old photos and see, you know, the chin changing and the supraorbital ridges changing. You need to see it, because it happens so slowly that your nearest and dearest won't recognize it, and that's why often and somebody here in the room was diagnosed by somebody who wasn't her GP at all, and it's often diagnosed by what I would call a spot diagnosis. Somebody suddenly says, oh gosh, that's abnormal. And that's the trouble with these pituitary conditions. They're rare, and they cause changes over many, many years, which are very, very gradual, and that's the difficulty. And it depends on who spots them for you. Right, now, I'm going to go through a little bit. So these are the things, one per 1,000 cases, 1 per 1,000 people. Now, I'm not going to talk about non-functioning tumours, because nobody's got one. So I'm going to miss that bit out. I'm not going to talk about prolactinomas, because, now, here we are, acromegaly. Now, this is a painting interesting, now, acromegaly was described about 130 years ago now by a man called Pierre Marie, who was a neurologist in France. And this is an amazing painting, actually. It was in Quebec. And now, I don't know if you can see it at the back there, but here's David on the left with the head of Goliath. And I think you'd agree, those of you who know about it, that the Goliath head has acromegaly because of his supraorbital ridges. He's got a big nose and rather prominent lips. This was before the days of somatostatin. And basically, he has acromegaly. And why did Goliath get killed? Well, what we think is that he had a big pituitary tumour, and that it compressed his eye nerves, and so he couldn't see David getting close to him to sling a stone. And that's how we all think that David got a stone into Goliath's temple. And it's very interesting that this painting was painted 100 years before acromegaly was first described, and there's some wonderful Rembrandt paintings of David and Goliath as well. Now, what are the effects? As you know, you get clinical effects of growth hormone, enlargement of the hands and feet, metabolic effects. You get diabetes because growth hormone interferes with the action of insulin. You get local effects. Sometimes the tumour can be quite big and you get the visual field defects we've talked about, and those are not uncommon. About 20% of people get those. But the characteristic thing is that in acromegalic patients, the tumour is small when the patient is over the age of 50 or 60, but usually bigger when they're younger. And then there are the endocrine effects of hypopituitarism, because the tumour presses on the eye nerves, presses on the rest of the pituitary, and then causes it to become under-functioning. And so therefore you need replacement with hydrocortisone, sometimes with thyroxine and with testosterone or estrogen. And so there are all sorts of different effects of acromegaly and of the pituitary tumour. And if you're not treated properly, there is really good evidence now. And this is why I was talking with Christine just now about how important it is that you have, for these complicated conditions like acromegaly and Cushing's, you have people who see them every day of their life, because this is quite complicated. You need a multidisciplinary team. You need an endocrinologist, an endocrine nurse. You need special X-ray specialists to be able to image the pituitary. You need oncologists who can treat the tumour with radiotherapy if necessary. You need histopathologists to be able to assess the tumour under the microscope. So you need a whole team of experts, and that is not the case in your local general hospital, where they do varicose veins and hernias and things, because it's really important that you have a proper team of experts who do this every day. And every week in Oxford we have a meeting, and we call it our multidisciplinary team meeting. It's good fun, because you're sorting patients out, often from quite long distances away. They don't necessarily need to come. You have their x-rays there, their history there, and so on. And then what we can do in a very expert way is actually to decide on their treatment. And what happens if you have a group of experts, then these patients actually get, their outcomes are better. And so what we have shown is that, firstly, if you have a surgeon operating on the pituitary, I haven't got this data with me, but if you have a surgeon operating on the pituitary, at the beginning they cure 50%, and as they get more experience, they cure up to 80% of patients. And so expertise is worth it. Now, the government will have us go to the local hospital for everything, but if you've got something that's uncommon, it's really important that you go to people who see it every day. And our surgeon in Oxford operates on 80 or 90 patients every year. And if you're operating on 6, as there is in one part of this country, then that's just not enough to have the experience and to have the outcomes. And that's important as well from the Commissioner's point of view, actually, because if you have people who are operating just once every few months, then the outcomes are not good, and then the patients need drugs at the end of treatment, and it costs the NHS more. So not only is it that the patient gets a better deal, but the cost of the treatment becomes less, because you don't have to go on expensive drugs afterwards. And that's important. And the downside of that is that you have to travel a little bit further. But when you've been dealt with and it's all sorted, you shouldn't need to go and see the clinic more than once or twice a year. So those are important things, that it's important. And this is a graph showing if you have a normal growth hormone, your mortality is the same, but if you have a high growth hormone, your mortality is increased. And that's why the biochemical things in acromegaly are really quite important. And what happens, I started when I was a littler boy, an acromegaly register in the country. We started this in 2009, actually. And what we've got is a group of patients up and down the country, because this was the way we wanted to get data in a hugely large cohort of patients, because if each individual hospital has 1 or 2 patients with acromegaly, they won't be able to contribute scientifically. And so we've put them all together. We've now got over 2,000 patients with acromegaly. And the important thing is that even with all the modern treatments, and there are, the prime treatment obviously is surgery, the next treatment is drugs, and then the next treatment is radiotherapy. And even with all of those things, it's not always easy to control the patients properly. And this is the numbers who weren't controlled according to their growth hormone and IGF-1. So I think it's really important, again, that you go to people who know what they're about. Oh, no, this is the surgical slide, sorry. And so this is our surgeon who operated on people pre-1981 when he became a consultant. And you can see his cure rate, his failure rate decreasing and his cure rate increasing. And so that's another really important thing, because if you're going to have an operation, it's really important you choose your surgeon properly, because they, you know, the surgical experience, the number of times they do the operation makes a huge difference to the outcome. I mean, I am a physician. The same number of patients will respond to my drugs. I might be charming, I might be a bit crotchety, but the same number of patients will respond to my drugs. But if you're a surgeon, then the difference is huge. And I think it's really important that that's put across. And that's what we're trying to do. And one of the things I was saying earlier is that for many of my sins I run endocrinology in the country in terms of trying to delineate where the services should be. And this is important because actually if you've got a group of people who don't have enough experience, then they shouldn't really be doing it. And so what we're trying to do is to delineate, amongst other things, where the pituitary centres should be up and down the country. Now, this is how to test whether somebody is going to respond to octreotide, and this is a study we did a little while ago. And this is another slide, a factual slide, which shows that if you've got a very high growth hormone level, your responses to the octreotide are less good than if you have a low growth hormone level. So if you've got a low growth hormone level between 5 and 10, 60% of patients respond. If you have a high level of growth hormone, only 14% respond. So I'm not going to talk about that because I think, and then how do we monitor acromegaly? And this is important. And so we'll measure the growth hormone and IGF-1. This is what you do when you come for your annual test. We look at the pituitary gland if necessary, but if they're cured, we use the growth hormone as a marker. And then we keep an eye on the blood pressure and the echocardiogram. We make sure that they don't become diabetic. One of the problems with acromegaly is that the joints can be affected because of their weight-bearing nature, so often the lumbar spine, the hips and the knees get worn out a bit, and that's something which doesn't necessarily respond to the treatment. And then we make sure that they haven't got other problems like a colonoscopy, because there is a slightly increased risk of colon cancer in acromegaly, so we measure and make sure that. But there's not an increased risk. There is not an increased risk of breast cancer or prostate cancer. So that's a little bit about what we do in acromegaly. And I just now want to turn to Cushing's, and then I'll stop because I want you to ask as many questions as you possibly can. Cushing's is the most difficult because it's rare. And the changes are very gradual. The problem with steroids, which are the hormones which come from your adrenal gland, is that they overridingly and overwhelmingly increase your appetite. And you can't help it. You just put on weight year after year after year. And the point is that Cushing's, as you know, causes this very unusual distribution of fat so that it's all in the abdomen and it's not in the legs. And so if I'm seeing somebody who has got a weight problem, and there's unfortunately quite a lot of those, then usually they've got thick legs and you can see that their muscles are quite overdeveloped. Whereas if you've got Cushing's, the muscles tend to be thinner, and so you have what's described to the medical students as a matchbox on sticks. And so you've got a big abdomen and tiny little legs and tiny little arms. And this is something which people don't recognize because it's so gradual, and it's actually, people just don't recognize the fact that also the face tends to go round and red. And the other thing which is difficult with Cushing's is that these patients actually, unfortunately, often develop some problems with depression and other forms of mental illness. And this also makes it very difficult that they may get seriously depressed, and that everybody thinks they're depressed and they're eating too much, and actually people don't tumble to the diagnosis. And so again, I think it's something which is really important that it's thought about, and then the treatment is usually okay, provided there is a tumour there, which can be removed through the pituitary gland, and those patients then actually need to be very carefully followed, just like the acromegalic patients. They need to have their cortisol measures regularly, and to make sure that they don't have a recurrence, because unfortunately there is quite a high incidence of tumours regrowing, even though they're very, very small. And so these patients, particularly with Cushing's, need to be kept a very careful eye on to make sure that the tumour doesn't regrow and that they don't develop mild Cushing's again. And then the other thing, there are lots of things which are important with Cushing's. It's very important to keep an eye on the bones, because steroid levels which are high often cause erosion of the bones and in fact cause osteoporosis. And this is important to keep an eye on your bones when you've had Cushing's, because they may become thinner than normal and therefore fracture. And so Cushing's is probably quite a difficult diagnosis, because there's so many things that can happen. And therefore, again, you're talking about going to see somebody who really sees a lot of it. And for us as endocrinologists, this is the most difficult one, because I think it's something which we need to keep a very close eye on. And it's the one, quite without question, needs highly specialized care. And I think that that's what's important about Cushing's. And so I'm just going to finish. This is, for those of you who saw my film, this is Chris Greener when he was a little bit younger. He's now 70, and that's me when I was a bit younger. I look like a growth hormone deficient titch, but actually I'm not that tall, but I'm not that short. Anyway, and so I come up to his nipples, actually, and he's a great character. He has a Mini, and he's taken the front seat out. He drives from the back seat because he's got very long legs. And we had to strip his varicose veins, actually. And you know, an operating table's 6 foot long. Well, we needed 2 because he's 7'6". And so we put his bottom on one and his legs on the other and stripped his varicose veins. And we needed, because he needed some chest x-rays done post-operatively, we had to put 2 chest x-ray plates because his chest is enormous. Anyway, but he's a real character. And when he came round to my house, my daughter, who was 8 at the time, just couldn't believe this chap had walked in. But he did love my wife's pea soup, and he asked me for the recipe when we were doing the filming. Anyway, so basically, these are the messages that you've got to diagnose pituitary tumours early. Because this man was 6'7" when he was 14. Now, this is very uncommon. But his GP said, "Oh, you come from a tall family, go away." And when he was 7'2", he came back again, and then that is quite tall. And then by that time, he had an enormous pituitary tumour, which we've now dealt with successfully. But I think the problem with pituitary disease is you've got to think about it. And if you don't think about it, you won't diagnose it. And I think, therefore, that's the important messages for us and all the medical people and our medical students, is to think about it before and during somebody coming in, because if you don't, obviously, you won't make the diagnosis. That's the end of what I'm going to say formally, but I really would welcome your questions. Thank you. Please.
Can I ask you where our nearest centre of excellence would be for pituitary conditions?
I thought I might get this sort of question. Very sensible question. Now, yes, sorry. Where is the nearest centre of excellence? Well, we think that it's either Birmingham or Stoke-on-Trent, because I don't think that this is a place that Shrewsbury anyway is not a place that specialises, as far as I'm aware, on pituitary disease. I don't know, here's our Lady Commissioner. But basically, Stoke-on-Trent has a significant pituitary practice. Professor Clayton, who's a friend of mine, is just about to retire, I think, or may even have just retired. But I think you'll find that there are people carrying on with that because it's a well-recognised unit. The other place that really is good, how long would it take for you to get to Birmingham here? An hour. Oh, that's fine. So, I mean, the other place that is really, and there are really good people in Birmingham, and John Ayuk and Andy Toogood and people like that, they're really good. And they've got a multidisciplinary team and they do lots. So the answer to that is it's either Stoke-on-Trent or Birmingham.
Thank you very much.
Another one.
Sorry. You mentioned that people with some of these conditions may be prone to certain types of cancer, like bowel cancer. So
Acromegaly, there's slightly more, there was a controversy about this.
So when they're screened for perhaps bowel cancer,
Very good question.
if it shows up, would they then automatically contact the GP, or how would you know that you might be at risk of something else if you have?
Right, this is a very good question. Very good questions all over. So if you've got acromegaly, you're slightly more at increased risk of getting bowel cancer. Therefore, with acromegaly, you should have a colonoscopy done if you present above the age of 40 at diagnosis. And then you either have it done every 2 years if your acromegaly is not controlled, or every 5 years if it is. So that's acromegaly. There is a thought that there may be other cancers involved with acromegaly. There is no data in the literature which suggests either that breast cancer or prostate cancer is you're at increased risk. And then in terms of Cushing's, the main increased risk is not a cancerous one. It's actually one of cardiovascular disease. So you need to make sure that the blood pressure's okay, they're not diabetic, and their cholesterol is okay, because the main risk of Cushing's is a cardiovascular risk. There is also a cardiovascular risk if you're acromegalic and you're not controlled, but that is not the case if you are controlled, according to the growth hormone and IGF-1 data. But there's no increased risk of cancer in Cushing's, but there is an increased risk of osteoporosis, which therefore every patient with Cushing's should have a bone mineral density done. Is that sensible? Does that help you? Please. Are the degrees of Cushing's? It can go on for years, but there's not a degree of it. So basically, you've either got Cushing's or you've not got Cushing's. But it can be very, I was saying this yesterday. It's very easy to be sure a patient's got something, but actually you may understand that it's actually rather difficult to be sure they haven't got something sometimes. And Cushing's is part of that because, as you probably know with Cushing's, you have a circadian rhythm of your cortisol. So when you get up, your cortisol's high, and when you go to sleep, it's low. And what happens in Cushing's is that goes. And so instead of being high in the morning and low at night, it's high in the morning and high in the evening. So there are various things that also cause an abnormality of the circadian rhythm. So if you're ill, or you're in heart failure, or you've got an infection. So losing your circadian rhythm is not specific. And sometimes people who are very, very overweight also lose their circadian rhythm. So, and that can be caused by the Cushing's, but also severeness of being overweight can also cause an abnormality of circadian rhythm. So it's sometimes very difficult to diagnose Cushing's.
I mean, I know what you mean by circadian rhythms, but I wonder, would my GP know?
GP?
I don't hope so.
Well, I think that you may need to explain it.
Most GPs would think that is.
Anyway, you may need to explain it, but I think it can be quite difficult because some people because Cushing's can make you quite ill, and then by the time you become quite ill, then you lose your circadian rhythms and your dexamethasone suppressibility, and so it can be that actually Cushing's is very, very complicated to diagnose, I'm afraid.
Can I ask you, in young adults, what is the effect on their fertility?
Of what?
Of acromegaly.
Of acromegaly. What is the effect of acromegaly on your fertility? And we should also talk about the effect of Cushing's on your fertility. So if, let's not make this too complicated. If you've got a pituitary tumour, which is a big one, what can happen is that the tumour presses on your normal pituitary, and so a woman will lose her periods and a man will lose his testosterone and therefore his libido and his erectile function. So it can affect your fertility. And so what can happen is the sperm count goes down or whatever. That is a reversible phenomenon if you operate and the pituitary function recovers. And it's also a treatable phenomenon because with a woman you can give her gonadotrophins. They used to get gonadotrophins by collecting nuns' urine and then boiling it down. But they don't do that anymore. And so basically we can make this gonadotrophin because it was menopausal gonad's urine, actually, because, of course, their gonadotrophins are very high then. These are the hormones which, when you get to the menopause, go up because your pituitary is basically flogging a horse which is not so alive as it was, let's say. So you can treat patients who are infertile with exogenous gonadotrophins. That's the technical term for the pituitary hormones which stimulate your gonads. So fertility is reduced in acromegaly. Fertility is also, and more significantly, reduced in Cushing's because cortisol levels actually suppress the gonadotrophins, the hormones which come from your pituitary, so that most women with Cushing's will have amenorrhea, and most men with Cushing's will have a low testosterone, and so their fertility is interfered with. And I came back, as you said actually kindly in your nice introduction, I was in Lithuania on Saturday, and I was giving a lecture on the pituitary in pregnancy, and so only a very small number of patients with Cushing's have ever been described as getting pregnant because 75% of them don't make eggs and don't ovulate properly. So pregnancy in Cushing's is very, very rare indeed.
Do you continue the medication through pregnancy?
For the Cushing's?
Yeah.
That's a very interesting topic. The answer is that you can do. But for acromegaly you don't, because the treatment like somatostatin analogues cross the placenta and can affect the fetus. So we don't in acromegaly, but if you've got a patient with Cushing's who's diagnosed in the first 3 months, because there's such a risk of diabetes and high blood pressure and such a risk of fetal problems, I would recommend a termination in the first 3 months, and if it's in the second 3 months, then you've got to try and carry them through. But it's a complicated issue. Happily, we don't see it very often. Now, any more questions at the back here?
You talked about the importance of the centres of excellence for operation.
Yeah.
How about post-operative outpatients? Is there cooperation from the commissioners
Yes,
to get
that's
them?
a very good point too. So what we're trying to do in the country now, and it's largely established actually, is, did you hear that question? No. How do we manage post-operatively? It's very important. The most important thing is getting a good surgeon. Now, what should happen is that when you have your operation, in some hospitals that know a lot about endocrinology, even though they may not have a surgeon, and in those places we will say, right, you get on and assess the patient post-operatively and follow them up. But you need, particularly with Cushing's and acromegaly, you need that degree of expertise to follow them up and make sure they haven't had a recurrence and so on. And so it's slightly flexible. I say in Oxford we have one department of endocrinology in Swindon which is very practiced and has got a really good pituitary endocrinologist. He doesn't operate, but I let him do all the post-op care and all the post-op management. But in another part of Oxfordshire where they're not so interested, we do it all ourselves and send the patient back when he or she is all sorted. And so it's slightly variable. The most important part of the multidisciplinary care is the surgeon and the surgical input, and if it's a keen team locally, they do the post-op care, and if it's not such a keen or knowledgeable team, then we do it ourselves. So it's slightly variable. Does that answer your question?
Well, the question really was, are the commissioners cooperative to paying out for post-operative?
Well, this is an interesting topic, actually, because it's something which is going through at the moment. So you may or may not know that the whole system has changed in the last 2 years, and there is now something called NHS England, and that's what... And they are paying for the highly specialised care, which is the group I'm in charge of in endocrinology. And what we've decided, what we've done is a specification of what we define as highly specialised conditions. And as I say, acromegaly and Cushing's are both in those. And therefore, the mastermind of the care should be in the highly specialised commissioning group and paid for by NHS England. That's the theory. I'm having a slight battle with the practice at the moment, but anyway, that's the theory, and I think that's what should happen in the next year or two.
So what is the actual treatment for Cushing's? What medication?
Okay, so what is the treatment for Cushing's? And the treatment for Cushing's, well, the first thing, because Cushing's, 60% of patients with Cushing's have a tiny little pituitary tumour, and in some of them it's so small you can't even look at the X-ray of the pituitary and see it. And so you may need to do highly specialised tests, which is another reason to go to a specialist unit. So the diagnosis of Cushing's disease, which is the pituitary form of it, is sometimes very difficult. Having said that, 60% of people have Cushing's. So the first thing with Cushing's is to make sure you know what you're dealing with. It can be pituitary, it can be a tumour somewhere else causing ACTH secretion, which causes Cushing's. That's about 10 or 15%. And then a small proportion of people have tumours of their adrenal glands which cause Cushing's, and they're easy because you just pop them in a scanner and there's the tumour. And so once you've made the right diagnosis, the next thing is to actually give them some treatment, and assuming now that it's a pituitary problem, then you go to a pituitary surgeon. And this is why, again, because the tumours are so small, and you can also damage the rest of the pituitary, that's where you need somebody who's a real expert. And so the first thing is to treat them with surgery. And then the next thing is, if the surgery isn't effective, then you treat them with drugs. And there are various drugs, including a drug called metarapone, which interferes with the production of cortisol from the biochemical point of view. And so there are various treatments of Cushing's medically. And then the third thing is to actually give them radiotherapy to their pituitary if there's still a problem. So those are the means whereby you treat Cushing's. Okay. Any more questions? Oh, good. Christine.
First of all, is there any evidence that when someone's been diagnosed with Cushing's or acromegaly, that it could be hereditary?
What a good question. Is it possible that Cushing's or acromegaly can be hereditary? It's possible, but it's very uncommon. I used to say that it was impossible. But actually, in the last probably 8 years, there's been some work, and there's a special gene which occurs particularly in young people. Now, I'm going to tell you a story, and then I'll come back to answering the question. So, have you heard of the Irish giant? The Irish giant was a man called Charles Byrne, and he lived in the 1750s, and he came over from Ireland, and he was 7 foot, same sort of height as Chris Greener. And he used to come, because they came from a poor family, he used to come and exhibit himself in circuses, and everybody would pay a shilling or what it was to see this chap. And then what he did, unfortunately, was to die, aged 22. And he said, I don't want anybody to get my body. So they put him in a coffin and heaved him down towards Margate. And there was a very famous anatomist called John Hunter who was desperate to get hold of his body. And so what they did was to ambush the people on the way down to Margate. They took his body out of the coffin, put some stones in it. So these poor people buried a coffin full of stones, and this man's skeleton is in the Museum of the Royal College of Surgeons. Now, how does that link up with your question? Well, when a few years ago I suggested to the person who discovered this gene, why don't you scrape the tooth of Charles Byrne in the Museum of the Royal College of Surgeons? And what she found was that there was this gene, and that when I was at Barts, had been looking after one of this man's relatives from several centuries down, from this very small village in the north of the southern part of Ireland. And so this family had this very rare gene, which was then described in the New England Journal of Medicine, which is our premier journal. And so Charles Byrne, this Irish giant, had this very rare gene. So the answer to your question is yes. You very rarely get acromegaly occurs in families, but usually it's in people who get acromegaly, and the same is true of Cushing's, when they're very young. They usually get big pituitary tumours, and these tumours are not so easily treatable with drugs. And so the answer is that probably about 10 or 12% of patients with a pituitary tumour, particularly if they develop a tumour when they're very young, below the age of 20 or 25, they may have a genetic variant, and there may be other members of their family who have them. But the vast majority of people who have a pituitary tumour have an abnormality of the genes of that tumour, but there's not a transmissible abnormality. Does that make sense?
Yes, thank you.
When I was diagnosed with acromegaly, a few years later I was diagnosed with prostate and colon colostomy.
A cancer?
Could the pituitary tumour cause the tumours in the rest of the body?
Good question. So the answer is that there is, as I said, I'm afraid, a slightly higher incidence of colon cancer in patients with acromegaly.
Yeah.
And if you do a biochemical test, some cancers of the colon have IGF-1 receptors on them. Now, you probably know, having acromegaly, what IGF-1 is, but it's the growth factor which causes the changes in your body of acromegaly. And so colon cancers have IGF-1 receptors, and so they may grow under the influence of growth hormone and IGF-1. And that's probably the mechanism whereby it's slightly increased. It's not increased greatly, but that's why we have our surveillance programs in our patients with acromegaly. With regard to the prostate, there is no evidence that acromegaly causes an increase in prostate cancer. But when we've got people on testosterone, because testosterone can lighten up an existing prostate cancer, then you may get a problem with that. And so when we've got people on testosterone, and this is important for all the men here who may be on testosterone treatment, that your prostate's checked probably once a year with a PSA. Yes. And that's important because you can treat these things, you can treat them early, as I say, the testosterone doesn't cause prostate cancer, but it actually lightens up prostate cancer, and therefore you need to diagnose and treat it early.
Yeah, right.
Any more questions? Right.
Thank you very much.
Sorry, I've gone over.
We're going to move into a